Hi, everyone. Thank you for joining. My name is Eugenio Rossi. I'm a psychiatry resident from Italy. Today, we will explore the emerging potential of psilocybin-assisted therapy for addressing a set of particularly challenging neuropsychiatric conditions, atypical Parkinsonian syndromes. These disorders present a unique therapeutic challenge because they involve both severe neurological deterioration and profound existential suffering, a combination that conventional treatments struggle to address. Before we begin, I want to acknowledge that IPN does not encourage or condone the illegal use of psychedelics. This presentation is intended solely for educational purposes. Before we delve into this topic, I'd like to introduce myself a bit better. My journey into research began with an early fascination for how the mind processes art and how our brain is able to construct memories that shape our appreciation for it. This curiosity later evolved into an interest for psychiatry. As both a clinician and someone living with bipolar disorder, I found value in trying to adopt a phenomenological perspective, focusing on what people affected by mental health conditions actually feel and experience. Over time, I became increasingly aware of the limitations of existing psychiatric treatments. This realization drew me to psychedelic research. And now, during my rotation at the Champalimaud Foundation, I work with the team investigating how psychedelic-assisted therapies might help people with chronic movement disorder confront existential suffering. To understand the context of our discussion, let's first look at the landscape of Parkinson's disease. This disorder represents one of the fastest growing neurological conditions worldwide. According to recent data, over 11 million people currently live with this condition, representing a stark increase since 1990. New cases appear at a rate of about 15 every 100,000 people annually, with higher prevalence in men and in regions with advanced healthcare systems. Both disability-adjusted life years and deaths due to Parkinson have more than doubled in the past 20 years. While Parkinson's disease affects millions, atypical Parkinsonian syndromes, or APS, represent a rare and particularly challenging subset. These conditions include a variety of distinct pathologies, like progressive supranuclear palsy, multiple system atrophy, and corticobasal degeneration. So, what sets them apart? In the first place, prevalence. Atypical Parkinson is 15 to 20 times less common, both in terms of prevalence and incidence. Secondly, age of onset. These disorders typically begin in the late 50s to late 60s. And lastly, survival rates. Median survival after diagnosis is barely 3 years for atypical Parkinson, compared to almost 8 years for typical Parkinson. Moving from the epidemiology to the individual level, let's consider the story of Antonio and Lucia, a fictional couple inspired by real experiences. Antonio, a retired history teacher, had begun noticing subtle changes. He fumbled with his coffee cup, moved more slowly, and sometimes lost track of conversations. At first, he and his wife Lucia assumed this was just regular aging. However, as months passed, these changes became more pronounced. One day, while the two were out for a walk, Antonio lost his balance and fell. Although he only suffered a minor back injury, the brain scans prompted the medical team to take a closer look. After a few days of observation, he was diagnosed with Parkinson's disease. This marked the start of a conventional path of medications and physical therapy. The situation carried a sense of uncertainty, and Antonio struggled to process what it meant for his future. After some months, it became apparent that treatment had brought little relief, as his symptoms kept progressing rapidly. Oddly enough, he didn't seem to suffer from the classic tremor he was expecting to see. Further tests led to a new diagnosis, progressive supranuclear palsy, a form of atypical Parkinsonian syndrome. The doctor explained that this condition is often mistaken for classic Parkinson in its early stages, but that APS is marked by balance problems, difficulty moving the eyes, and a limited response to standard medications. As time went on, Antonio's speech became slower and less clear. Conversations with Lucia were often punctuated by long silences, and she noticed he was more withdrawn and less motivated to engage with others. For Antonio, the hardest part was not just the physical decline, but the sense of losing hope and purpose. He described feeling stuck between worlds, physically present, but unable to participate fully in life. The prospect of further decline and the nearing of death weighed heavily on him, leading to periods of sadness, anxiety, and a persistent sense of meaninglessness. Lucia kept supporting him every day, but both felt deeply isolated in their experience. One day, during a follow-up visit, their doctor mentioned a clinical trial which was about to start recruitment. It was aimed at investigating psilocybin-assisted therapy for people living with APS, and he said Antonio would be eligible to take part. He gave them an information sheet and told them to take their time to think about it. That evening, the couple started looking up information on psilocybin. The reason why I wanted to share this story with you is that when discussing these chronic conditions, it's easy to get lost in the clinical terminology. But as we know, behind every diagnosis is a human story, a narrative of adaptation, meaning-making, and often profound suffering. As you might have realized by now, atypical Parkinson are distinguished from typical Parkinson not only by their rarity and rapid progression, but by the complexity of their symptoms. Patients experience significant coordination problems, leading to frequent falls. Vertical gaze paralysis, which makes it increasingly difficult to look up and down, can make everyday activities very challenging. Cognitive decline often appears early, and unlike the later stage dementia seen in Parkinson, APS patients tend to remain aware of their own deterioration. Autonomic dysfunction, including bladder and swallowing problems, further complicates cases. To fully understand APS, we must look beyond motor symptoms to the psychological dimension. At initial diagnosis, about half of patients screen positive for depressive symptoms, basically double the rate we see in typical Parkinson. This isn't simply a psychological reaction to the diagnosis. It's also a consequence of the neurobiological changes caused by the disease. As the condition progresses, more patients develop clinically significant depressive symptoms. And given the rapid progression and poor prognosis, patients are forced to confront mortality and loss of self at an accelerated pace. Perhaps most critically, psychological flexibility is severely impaired. This gives rise to rigid thought patterns that amplify suffering. This combination of factors constitutes the premise for existential distress. Despite significant advances, there remain substantial treatment gaps for atypical Parkinsonian disorders. As you might imagine, these conditions are less researched, resulting in fewer specific therapeutic options. The existing approaches present serious limitations. Most critically, conventional approaches rarely address the existential and psychological dimensions of the disease. The suffering caused by APS extends beyond the patient, creating what is known as a double burden. Patients struggle with progressive physical and cognitive decline, while caregivers, often spouses or family members, face their own significant challenges. Studies show that caregivers of APS patients spend an average of 7 hours per day on care tasks, and many develop symptoms of depression or anxiety themselves. The emotional strain is compounded by ambiguous loss, a situation in which the caregiver mourns the gradual psychological or emotional absence of their loved one. Improving the psychological state of the patient can benefit caregivers, and supporting caregivers can, in turn, improve patient outcomes. Yet most current approaches fail to address this interconnected dynamic. In recent years, psychedelic research has started to uncover new possibilities for treating complex conditions. Psilocybin, the compound present in magic mushrooms, has emerged as one of the most promising candidates for therapeutic applications. Unlike conventional daily medication, psilocybin typically involves 1 to 3 dosing sessions, with effects that can last weeks to months following treatment. Recent clinical trials have demonstrated psilocybin potential in treating conditions ranging from treatment-resistant depression to end-of-life anxiety, especially when delivered in the context of a structured psychotherapeutic intervention. Psilocybin's effects are multi-layered. At a cellular level, it acts as an agonist at the serotonin 5-HT2A receptor, which is abundant in brain regions involved in cognition and mood. This activation promotes neuroplasticity by increasing levels of brain-derived neurotrophic factor, which supports neuronal growth and connectivity. At the level of brain networks, psilocybin disrupts the default mode network, a system associated with self-referential thought and rumination. This disruption can allow for new perspectives and break maladaptive thought patterns. At the experiential level, psilocybin can induce mystical or transcendent experiences that are strongly correlated with lasting therapeutic benefits, including increased feelings of unity, acceptance, and meaning. One of the most intriguing aspects of psilocybin therapy is the concept of a neuroplasticity window, the period of approximately 2 weeks following administration, when the brain exhibits heightened capacity for change and learning. This window may represent an optimal time for targeted therapeutic interventions. When we think about patients with these disorders undergoing these treatments, we need to bear in mind the unique needs of this population. Psilocybin could be strategically leveraged by aligning additional interventions, such as physical rehabilitation, cognitive training, or psychological integration. Given the cognitive impairment, it is important to adapt the process accordingly to ensure that these experiences are not overwhelming and can lead to their intended benefits. The psychological effects of psilocybin-assisted therapy extend beyond symptom reduction. Patients often describe transformative experiences that reshape their relationship to illness, suffering, and mortality. Mystical type experiences can foster a sense of unity and purpose, even in the face of progressive disease. Enhanced emotional processing allows patients to engage with difficult feelings such as grief, fear, and anger, rather than suppressing them. Studies and case reports have documented increased psychological flexibility and acceptance, helping patients adapt to changing circumstances and maintain a sense of meaning. A recent pilot study marks a significant advancement in our understanding of psilocybin's potential for mood dysfunction in Parkinson's disease, a finding with important implications for atypical variants as well. In this trial, 12 individuals with Parkinson's received 2 doses of psilocybin alongside structured psychotherapy. Overall, the treatment was well tolerated, and what stands out is the benefits observed across multiple domains. Motor and non-motor symptoms both improved significantly, with non-motor symptoms such as mood and sleep showing relevant effects. Most importantly for this context, depression and anxiety scores dropped substantially, and these improvements persisted for at least 3 months after treatment. While this was a small open-label study, these findings provide the first evidence that psilocybin can be administered safely to people with neurodegenerative disease, and suggest it may offer benefits that extend beyond mood to motor and cognitive symptoms. I'd also like to mention the EU-funded PsychedelX trial, which represents a pioneering effort to extend research on psychedelics, specifically to patients with degenerative illness, including atypical Parkinsonian disorders. This trial aims to assess whether psilocybin-assisted therapy can meaningfully improve quality of life and reduce psychological distress in these conditions. As we consider the promise of psilocybin-assisted therapy for these disorders, we must also acknowledge the significant challenges that remain. The evidence base is still in its infancy, and long-term effects in these populations remain largely unknown. Patient-specific considerations are crucial, including managing psychiatric comorbidities and medication interactions, addressing physical limitations, and ensuring adequate social support. This necessitates highly individualized care. It's also important to ensure informed consent despite cognitive vulnerabilities. Access, equity, caregiver involvement, and sensitive end-of-life applications also require careful considerations to avoid misconceptions and ensure responsible development. While our topic today has been quite specific, its implications extend far beyond these conditions. The protocols developed for APS could serve as templates for treating other degenerative diseases like Alzheimer's, Huntington's, and multiple sclerosis. By addressing both the neuropsychiatric and existential dimensions, psychedelic-assisted therapy also holds promise for depression, traumatic brain injury, and end-of-life care. The most promising path forward involves integrated care models, combining psychedelic therapy with evidence-based interventions. Leveraging the neuroplasticity window after psilocybin administration, multimodal rehabilitation could include physical, occupational, and cognitive therapy. Caregiver-inclusive protocols and earlier palliative integration can further enhance outcomes. And additionally, emerging non-hallucinogenic analogs may offer neuroplasticity benefits without perceptual effects, increasing accessibility for cognitively impaired patients. Before concluding, I would like to disclose that this presentation was developed with assistance from AI tools. The insights, clinical experience, and critical evaluation of evidence remain my own. For those interested in exploring this topic further, I'd like to highlight some key publications that form the foundation for this presentation. And this work is the result of collaboration, mentorship, and inspiration from fellow researchers, colleagues, and patients. I would like to thank all the IPM and PsychedelX team for this opportunity. Special thanks to Olivia for her amazing tutorship and to Jack and Andy for sharing this experience together. I'd also like to acknowledge all the dedicated individuals who initiated this field and those who carry it forward every day despite all odds. I extend my gratitude to all of them for their trust and guidance, and to you for watching this presentation. On a final note, I'd like to highlight a tangible way for European citizens to support the advancement of psychedelic research. Psychedelic Care is an initiative that aims to create a more adequate regulatory framework for psychedelic research and medicine across the European Union. Thank you for your attention.